Welcome to the Future of Dermatology podcast. I'm Dr. Farah Kamangar. What you're about to hear is a standout session from this year's SF Derm Conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
What do you all use for your initial workup for chronic urticaria? What tests do you do in what cases? Heavy question.
You're going to get a different answer from each one of us, probably. I am in the camp of doing nothing. I really don't do any specific testing initially, especially if it's the first time that they're getting a diagnosis and we haven't tried anything yet. Generally, I will consider doing testing if we've tried high-dose antihistamines and it hasn't been effective. We've tried omalizumab and hasn't been effective. Then I'm like, all right, let's just get some labs to see if we're missing something. But in the end, it really doesn't change management. And study after study after study after study has shown doing testing is not cost-effective. You rarely find anything unless there's something already very strange about the history. If there's some weird stuff about the history, absolutely. I think it's very reasonable to do some studies. And again, the international guidelines are different than the US guidelines right now. That will change. But the international guidelines does recommend, let's get a basic CBC, let's get some anti-TPO, inflammatory markers, total IgE. Like you can totally do that and justify it. But I really don't think it's necessary, at least initially.
I have a question. It used to be more common for people when they were considering autoimmune urticaria to do specific testing, Fc epsilon receptor IgGs. Is that like gone because people just treat, or are people still doing that? We do consider that.
I think it was gone because all we had is omalizumab. So it didn't change anything that you did, right? You're going to put them on a high-dose antihistamines. You're going to put them on omalizumab. It doesn't make a difference whether they have these antibodies or they have low Ig or they have high Ig. It doesn't matter. Now that we're getting more therapies, I don't think it changes that much for dupilumab either, because it probably doesn't make a huge difference when you're deciding OMA versus Dupi lab-wise. But with remibrutinib, with the KIT inhibitors, it may change that if you do have more of the autoimmune type versus the autoallergic type. But when we think about these, like again, I take care of a lot of nasal polyp patients. I take care of a lot of asthma patients. I'm usually deciding biologics more often based off comorbidities than I am on specific lab results right now. Again, that may change 5-10 years from now, but our biomarkers stink. They're not great. And so I don't think it's worth it for the most part.
So, I mean, I'm generally in the same camp, except, I mean, like, and I give the same spiel that Dr. Joshi does, and I'm very proud I give that same spiel until a couple years ago, one of actually our joint allergy derm research fellows, Dr. Alexis Tracy, who's now at Duke as pediatric dermatologist, she called me up when she was a resident in New York, and she said, "Hey, I got a 48-year-old who's came in with just CSU, nothing else." And I kind of just went and did a CBC, and it was completely out of whack. And then we sent them and did a smear, and then ended up being the first presenting symptom of CML. So then it was interesting because we actually ended up writing the case report up, and because the use of imatinib and got rid of the hives much faster than it did the cancer. And, you know, it makes sense because with the c-KIT inhibition, et cetera. So we actually ended up publishing that. So now whenever I tell patients, I said, you know, I give the same spiel, I'm like, but please don't look me up, because then you'll see something that's like, I mean, like first thing, like, I mean, CSU, like, I mean, first sign of cancer. So listen to what I'm telling you. Don't look me up. I mean, like, because you may end up seeing that. But honestly, from a testing standpoint moving forward, I mean, we have now different therapies, BTK, c-KITs, JAKs, et cetera, that, you know, perhaps defining the autoallergic and autoimmune subtypes may be more beneficial. And I don't know yet, you know, like whether doing that differentiation helps with dupilumab, because, you know, people had mixed feelings about the Qubit B study. And in some ways, I mean, if you read it depends on how you read the study. If you read it a certain way, it actually shows that it does potentially confer some additional benefit in omalizumab refractory patients. And we have to remember sort of where IL-4 sits. And IL-4, I mean, it's class switcher combination to IgE and IgG to a lesser extent. So as well as having a direct impact on the sensory nerve. So, I mean, it may be broader than omalizumab. It's still hard to say. So I think that we do need to kind of dig a little deeper into the Cupid B study and think more down the road in real world evidence and how that can be beneficial.
Yeah, I'm just to close out the panel. I'm actually more like Shyam. I rarely do testing, and mostly because it doesn't impact the decision making. I also same with psoriasis, where I really spent most of my training was, these patients have inflammatory bowel disease? Do they have psoriatic arthritis? Are they at risk for candida infections? I think we tend to go that way in those disease states. Pretty much have done the same in CSU, but again, our only standard therapy that we could get approved beyond antihistamines was omalizumab. And I personally believe that the reason we created a lot of the testing was because we had an anti-IgE therapy. And I think it made sense to check IgE because it makes sense that IgE could predict a poor response in those patients that had disease that wasn't driven by IgE. And that sort of makes sense that if you have these patients with take atopic dermatitis that have some other circuit that's not IL-4 and 13, they're rare, but it happens, then makes sense that you might need to hit something different. I think one of the difficulties that I think we're seeing now in our specialty, you're hearing about things like, does dupilumab cause CTCL? Well, this is an interesting case here too, because what did they call that patient? They said, I have a patient with CSU, who then I started doing a workup and found out they really had cancer, right? And I think in the same concept, when people don't know what they really have, they pick a label. We do that with psoriasis, we do that with atopic dermatitis, and then we find out that actually all along they had CTCL. We just called them AD. Why? Because we have these really poor biomarkers, and then we're like, well, I had them on for 5 years and they developed CTCL. Dupilumab caused it. It's like, well, but you picked something. I mean, I had no way of confirming it. So I like to talk to patients about the idea that we're still clinicians. We make a clinical diagnosis, and most of the time these labs don't change a lot of what we do. And if we have these really good biomarkers, it would be helpful, but we don't. And so if we focus on therapy, it kind of makes a big difference, because we don't really find a lot of these cases where they're one-offs. But again, we're chasing those zebras. And I think it's challenging. And I also think the negative consequence of it is you're reinforcing to the patients that, hey, we might find something. And so those patients are like, I might be that one zebra that I heard about in New York. And I think it gets it back to that thing. And that can be sort of a downward spiral too. So I like to say, look, the data's there. Let's get you better. And if we start to get you better, you can still do all the workup you want afterwards, right? If you want to go get your cancer screens, great. But let's focus on the symptomatic management. And I think that changes the dynamic. So it's not do I need to really go to allergy to figure this out? It's that let's just get you better. And most of the time, that testing that you do subsequently, it's not going to be impacted by the therapy that we do for the most part.
I'll just add more confusion to this, but I do think one of the reasons why dermatologists send patients to allergy immunology is because of that same scenario where someone says, but what food is it? And you say, all the data has shown that's not a food. And then their next question is, but if I stop eating this, will it go away? And I think it was always convenient for us to say, well, the person or people with the treatment that will help you the most also can do that testing. Now, move forward. So I do think there's something to that, and ordering some initial labs has been therapeutic for the patient in those circumstances. So I tend to do a CBC with differential and then the ESR CRP, which I think were the European guidelines a couple of years ago.
I'll fess up as well. I was going to stay quiet, but I tell patients, especially because we see a lot of acute urticaria or sort of early chronic, and we often explain that there's no cost efficacy for drugs. and say, but if you want it, if it's still going on in another 2-3 months, we'll do some screening labs, which we can't rationalize the expense of, but if it's reassuring for you, but understand there may be a positive test you end up tracing, and I'll sometimes do that even though I know I can't rationalize it.
Yeah. And I wonder how that'll change as dermatologists have more in their armamentarium. So on the same thing,
One last comment. Please don't tell the patient, go to the allergist, they'll test you. It sets us up for disaster. I've gotten so many negative reviews that, hey, the doctor referred me to use to test, and I'm like, that's not appropriate.
Yeah, and so they don't want to. That's
We like the patients, we just don't want to be set up for failure.
Yeah, and just to kind of reinforce that as well, it's like, I mean, like, chief complaint sometimes is like, oh, why are you here? I'm here for testing. And I'm like, well, I'm not radiology. I'm not like, I'm not here. I'm not just doing a procedure. It's like, I'm here to evaluate you. And like, and I think that, it's just one of these things where right now you guys are keeping, are sending 9, keeping 1. At least we keep 3 to 4. Moving forward. So, because we can't have, we can't send all of them over.
with you, I think all the derm residents are feeling the sympathy because of the call they got last week of consult for biopsy. So we feel you there. Let's keep going on the theme of lab testing. Dr. Eichenfield, this one specifically for you. So the question is, in pediatric patients with recalcitrant AD, if any screening tests, what would you consider for your immune deficiencies? What do you guys order in your
So first of all, the
clinic?
screens for immune deficiency will be growth chart. Okay. And history of infections other than skin infections. Those are probably the 2. And I'll add a third, which is funky morphology. And that's not nummular, because if you ever look at people's pictures of bad babies, there's often a lot of nummular component. They'll have typical AD, but then these very nummular inflammatory, but stuff that looks psoriasiform, atypical distribution, because you can have Nethertons and other conditions. Those 3, morphology, growth failure, and most importantly, infections other than skin infections are probably the trigger to consider immunodeficiency. You can decide if you do more than that. Other than that, laboratory testing isn't part of what we generally do, because we know we can use, even if we need systemic agents, we don't necessarily need to screen. I do change that on occasion, as Bob was relating our real life issues of families who come in with what we call train wreck babies, but they don't want to treat with anything. They're waiting for the kids to reboot. And so sometimes we'll get an IgE level on those patients because they come back like, 3,400, normal's up to like 60. So a way to explain that there's a systemic process going on. It's not just in the skin. So we'll sometimes use that. And then, of course, if there are specific concerns about allergy, we'll send them to Dr. Geng to test them. No, just kidding. They'll be evaluated as necessary, but there's not a big lab workup in most of those patients.
I just want to kind of add that, from an immune deficiency side, because we run a pretty large immune deficiency program too, that, there's a lot of telltale signs of this. Certainly there's a number of like Ullman syndrome patients, IPEX syndrome patients, Joe syndrome patients. And a lot of these different conditions, but and that's one of the benefits that we sit there, we kind of talk through this, is that there's something off with this. AD patients generally have very high IGs, but this person's IG is very high, but also has a few other features. A lot of it is detecting, and sometimes we will test, but I do want to emphasize that it also goes the other way too. There are secondary immune deficiency patients due to, basically having like no skin barrier, because we've had a couple who were checked because of such profound protein loss, especially in the little babies, that they look hypogammaglobulinemic, and they end up with infections. But then we treat the skin, and it's actually, and then their hypogammaglobulinemia improves, and it's not because they have a primary immune deficiency, but it's really because they're losing all that IG through the skin.
The only other thing I would add is family history, is taking a really detailed family history, especially for X-linked conditions, which a lot of these immune deficiencies are. So if just taking the time to do that, and that's a really good screening tool.
I was just going to say on the clinical trials, for those of you who have done clinical trials, one of the really interesting things that happen is that, these companies make you check all these labs that probably don't have anything to do with the diseases for the most part, but they're having to make sure these patients are healthy and their liver enzymes are good. And so we do labs every visit, very routinely, about every 4 weeks. Well, we take these patients all the time that have recalcitrant atopic dermatitis or recalcitrant AS or recalcitrant psoriasis. Why are they in clinical trials? Because they failed all the other therapies. And so it's interesting because we get to watch their labs every 4 weeks. And we do this all day long. And it's interesting because you'll have someone who is fine, and then week 16, they'll have some crazy lab. And then week 20, they're fine. And so, 95% of the time we report adverse events, which we don't believe are adverse events, but patients said, oh, I had a cold, so I took NyQuil. We have to report that. Or their LFTs went up, and we have to write that as, elevated LFTs. And so for the most part, you watch these patients and we don't see these consistent problems. It's not like you take these really severe AD patients that failed everything and we suddenly pick up all these lab abnormalities. Same in our CSU patients. And so I think we get a unique thing because nobody's checking labs every 4 weeks except us because it's imposed on us. And so you kind of get this artificial experiment where you start to watch that and we don't see it. And the variability in labs, IG is a great example. We'll have people that'll come in, it'll be like, 1,300, 1,400, and the next visit there's 600, and then the next one they're 1,100. Like there is huge variability still in some of these labs. So it's really hard to make meaning if you order it one time and one data point. We see multiple data points and I still can't make sense of it. So I get a little nervous when there's huge variability. What are you going to do with one data point? It's really tough.
Yeah, and that's a really important point. I mean, there's kind of a high degree of variability in clinical trials for a lot of these excessive labs. Oftentimes, I mean, is the bane of my existence, and I'm sure it is for you as well. And it also highlights to us in clinical practice when we have to do this for research, but in clinical practice, I mean, don't order excessive labs because and one data point in time oftentimes does not paint a complete picture.
Well, I just want to thank you all from the panel. This is just such a wonderful collaborative group. Thank you. And thank you to SF Derm for being so innovative in your approach to educating.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.